Welcome to the Really Know Your Customer podcast with your hosts, Betsy Westhafer and Tony Bodoh. Join Betsy and Tony as they dive in with highly successful C-suite leaders who have grown successful organizations by creating a laser focus on listening to their customers and building deep customer relationships. Now, it's time to join Betsy and Tony for the Really Know Your Customer show.
Hi, and welcome to the Really Know Your Customer podcast. I'm Tony Bodoh.
And I'm Betsy Westhafer. We're so glad to have you here today.
And today we have an amazing guest. Her name is Tanya Mack, and you'll learn all about her in just a minute, but I'll tell you why I'm excited about this episode. I'm so excited about this episode because we're going to talk about the massive shift that has happened in healthcare over the last few months. And the person leading the way in many cases has been Tanya.
Yeah, I'm so excited too, Tony, because Tanya has just been way ahead of her time. And now people are learning from her years of experience in telehealth back before people knew what telehealth was. So with that, Tanya, we want to welcome you to the show. Thanks for being here today.
Thank you so much for having me. I'm excited to be here myself.
Yeah. So Tanya, let's start off just by giving our audience a little bit of background into who you are, your current role in your company, and what the journey was that led you to this point.
Right. So my name is Tanya Mack, and I'm president of Women's Telehealth. We have been in business in the telemedicine business for 11 years. So way back then was kind of, although telehealth has been around, kind of a bleeding edge in telehealth, and we'll talk about all that's changed. My business specifically is more of a niche market in telehealth geared towards specialty care. So in the past 3 months, a lot of Americans have experienced the Zoom kind of telehealth for primary care and low acuity things. On a scale of 1 to 10, mine's way more complicated, but still a lot of change. It's more high tech. So I'd say on that 1 to 10 scale, we're about 8 or 9. And we provide high risk obstetric services to areas where moms don't have maternal fetal specialists. They just have OBs. And we work in government clinics. We work in doctor private practices. And we work in hospitals as well. So we've been in a variety of settings. So right now we've completed probably about we've done about 35,000 high-risk OB telehealth visits over the past years.
That to me is just mind-blowing. I mean, to think about what you can do virtually now that nobody ever had considered is just amazing. What are some of the procedures? Just give us some kind of practical applications of what this means to your patients.
Right. So all of our patients are really B2C, B2B, because they're already seeing an OB somewhere in their community. Although where I sit, we're based here in Atlanta, Georgia, we have 39 counties that have no obstetricians even, no delivering hospitals even. And so in a more rural setting, you might be driving to the next county over or whatever. On top of that, if you have a problem pregnancy, like I have twins, I'm diabetic, I have a chromosome abnormality, you will be driving probably a long way to see a specialist. So again, for a frame of reference in Georgia, there's about 30 of these high-risk specialists called maternal fetal medicine. They do an extra 3-year fellowship, the providers on top of their OB residency, and they're usually based in an academic center or a large tertiary care hub. Like in our state, we have Atlanta. And so we have a few scattered around the state, but if you're pregnant with twins in the mountains of Georgia, you'll be ambulanced, helivaced, something like that if you have a problem. But 10 years ago, my business partner and I were 50-50 partners. She's a physician. We had worked together at another company. She called me from Emory and said, we have found the next thing that we can help so many people with. It's telemedicine, where you can pipe in an audio-visual call like we're having right now. And on top of that, we have Bluetooth stethoscope. So I literally can put a stethoscope on a patient that's pregnant in a riverbed of Guatemala and hear her heartbeat in my ears in real time. I can also scan her baby with a portable ultrasound machine, port it up, pull it down on my side, and watch and direct in real time what is happening with her unborn baby. So we have a lot of connectivity points beyond healthcare Zoom to make all of that happen. But really, it's a way to pipe in high-risk specialty services where there aren't any. And interestingly enough, when we started, we thought it would all be rural, right? Like all our patients will be rural. Our first customers were 5 hours from Atlanta. But today we're 50-50. We're 50% urban in a big city, and we're 50%. You think big hospitals have the specialty, but they either can't recruit, or they're not enough, or their service area is wider than they can service, or there's some circumstance. So we're finding over time that what most Americans thought telehealth was only for if I can't get access rurally, or I've got to drive or get a long way. Now, of course, we're all in our homes. It's everywhere.
What's fascinating to me that you go into this, 10, 11 years ago, and you say, this is who we think our market's going to be. This is how we can serve them. When did you kind of take us back? You started out with the expectation that your customers were going to be in the rural hospitals and the rural areas of the country. And now you're at 50-50. What did you see that started to cause that shift, or when did you see that start to happen?
Well, first, whenever you start a new business, especially in tech, you just have to learn how to use it, right? So our very first customers, we actually made a grid of who would be our potential customer. And so for us, it was anybody that had enough OBs in their community that they could refer patients. They were at least a 2-hour drive from any resource that we would offer. And they had the technology, or were agreeable to having the technology in their clinic. So we went around rural Georgia and we made this grid, and we started talking to medical practices and hospitals that we thought might be our very first target customer. We did a revenue sharing plan with them because really I'm seeing in telehealth, we have the host, which is the provider, where are they sitting? And we have the presenting site, which is where the patient's sitting, which can be pretty far apart or not far apart. In our first customer case, it was about 5 hours apart. And so we revenue shared with them because in essence, we rented back part of their space and part of their staff to be our hands, our eyes, and our ears. And so we created a model and we learned how to do it. So step one was learning how to do it, right? Then it's gradually getting more credible customers after you yourself are comfortable with what you're offering and you kind of have some expertise. Then it begins expanding, growing your company and finding new customers. Along the way, Tony, you asked, so when did it kind of switch to urban? We never marketed to urban, which is kind of interesting. I think a mistake we make in talking about our customers is way too many assumptions about who they might be instead of who they really are. We never marketed to hospitals, and we never marketed urban. But we had been in practice before here in Atlanta, and one of our old brick and mortar referral sources called us with Obamacare and said, we know you have the technology to pipe it in. If we send our patients to the hospital right across the street from you and us, they're going to pay about a $1,500 deductible. It was right when healthcare deductibles went from $1,500 to about $10,000, $5,000 to $10,000. And then they said, look, our patients that are high risk are going to quit going because they can't afford through a 9-month pregnancy to pay $10,000 on top of their delivery out of their pocket. But if you wire our OB office right here in town, then they just got to pay their $40 copay. And we never marketed in town ever. And so we thought, oh my gosh, well, why couldn't we do it? And so we did, and they became one of our customers. Then we started looking at hospitals. So hospitals for us, again, I think you need to know when you really have value to your customers. So for us, a general metric or driving metric is the number of births per year. So if a hospital has somewhere around 4,000 births per year, they typically can afford and have the volume to have one of our specialists there or a specialist there. But we, again, made incorrect assumptions that, okay, well, maybe all hospitals over 4,000 have those kind of specialists, so we shouldn't waste our time there. In reality, we get another call. We're in a capital city in the United States, Montgomery, Alabama. We've tried to recruit one of you doctors for over 10 years unsuccessfully. We're in the middle of the state. There's nothing around. We have 3 delivering hospitals here and no specialist. And we heard about you through a conference, and we want to see if this might be right for you. And a strategic partner walked us into the C-suite. And so again, it was an incorrect assumption about who your customer really is that got us thinking we really need to broaden who our target customer is even. And so that is how we flipped the switch from rural to urban, from people calling that were prior customers or people calling trying to fill a need and they were just frustrated and they heard one little thing that made them pick up the phone. So listen to me, broaden who you think your customer is and don't assume.
Yeah, that's a point that we talk about all the time is just validation, making sure you aren't just throwing stuff up against the wall to see what sticks.
Right.
Tanya, 2-part question. One, where did you start off that led you to this point in your career? I'd be really interested in sharing your journey to get you to this point as an entrepreneur in this very specialized space. And then the other part of the question is, okay, you've gotten to where you are now and you've got so much of a head start on other companies in telehealth. What's happening now with COVID and people? I'm sure, we know this for a fact, your phone has been blowing up since COVID hit. So just kind of talk us into how you got to where you are now and what's happening now as a result of your experience in this field.
Well, it's interesting, entrepreneurs, it must be in your blood. So my formal training, I went to Ohio State, up by where you sit, Betsy. Betsy's in Ohio, I'm in Atlanta. And I graduated with a nursing degree, thinking it was such a broad field, and I knew I did not want to spend years and go into debt to be a physician, but I loved science and healthcare. So I was trained as a nurse, and then I left when my husband graduated from engineering school, moved to California, and got introduced to the business of healthcare by working for Johnson & Johnson. And they were starting a home health adventure. They mostly are known as a product company, not a service company. And I remember interviewing and I said, I think you guys need to hire people that know how to talk to doctors. They are not going to see you as a service company. And so they said, no, everybody knows who J&J is, Tanya. Like, we are talking about you from a nurse. We're not worried about the business. They opened the doors to the first home health agency that Johnson & Johnson owned in Los Angeles. No one came. Nobody. So they called me back and said, hey, that thing you were telling us? That was right. They actually sent me to sales school. So I got into the business of healthcare and never went back to the clinical side. So I know just enough to be dangerous, but I was an excellent nurse. But I kind of gravitated into the business of healthcare. The other thing is my parents were both small business owners. So my mother was a home builder and my father had an electric and sign shop that did crane trucks. So when you hear about payroll taxes, employees, all these things around the dinner table as a kid, I think that when we come to a risk decision, I'm not going to be an employee, I'm going to be the employer, flipping that switch. If it's always kind of been part of the conversation of your life, it doesn't seem quite so scary. And so after some years working in corporate America, I ended up moving back here to the East Coast to be closer to family. I connected with my current business partner. We grew an OB practice from 2 million to 40. We sold it to a big practice management company. And then she called me 3 years later and said, we did so good the first time. Let's do it again. I'm calling you from Emory. I found telehealth. I want you to see it. We did everything backwards in business, by the way. So I don't have a business degree, but I certainly as a CEO had to learn budgeting, balance sheets, and profit and loss along the way. We ended up finding the customer first. We looked at the demo of the equipment. We bought the equipment from Rubbermaid if they would sign a cross-selling agreement because we didn't even know how to do telehealth. So we saw it at Emory. It was fascinating. The rep that was doing the demo, we said, look, if you'll sign a cross-selling agreement, we will buy this machine now. We put it in her garage when it was delivered, and we'll go hunt for a customer. After we made our little grid and we signed our first deal, then we did the legal work for the LLC. So we were never without revenue. It was day one. but totally not the business plan, go get funding path at all. So that's kind of how I came to be in telehealth today, through relationships, through a comfort level with taking some risk, probably from my family. My brother was the same. He opened 3 businesses by the time he was 18 years old. We've always kind of had that in the family, made more money than my dad by the time he was 21. And so it's kind of just always been a thing that we've done. And I guess you always feel like you pivot or you learn to adjust. So it doesn't seem so scary that it's just taking the weight of the world on your shoulders. Although as an employer, definitely feels like that sometimes, doesn't it, guys?
Oh, absolutely.
So that's kind of how I got from A to B. I do want to talk about what has happened in the telehealth field since COVID-19, because it is one of the most, when we look in healthcare in hindsight 10 years from now, it will be one of the biggest pivots that we've had. It certainly has been in my career, and I bet it will be for the rest of my life. So having spent now 11 years in telehealth, we, in about 7 days' time, we erased about 30 years of barriers for telehealth adoption, and we probably advanced telehealth in 1 week about 5 years sooner. So we had limitations in telehealth that prevented mainstream telehealth adoption. I'll tell you what the 4 big ones were. The first one was devices. And so if you want to get to your customers, right, you have to look at where are they going. And so most of our customers are here on our phone. And so even for me that's connected through hospitals and things like that, being able for a patient where they sit on their phone, their desktop, their mobile especially, we were never allowed to use technology platforms like Skype, Zoom, Teams, anything like that, because then they were not Hipaa compliant. Doctors did not know how to use them. We were not paid for smartphone use at all. And so the devices that became allowable in 1 week, like throw it out the window. If you have a smartphone, call your doctor. Hey, doctors, just FaceTime your patients. It's all good. We don't want you coming in and exposing anyone. However you can get connected, do it and we'll pay, all right? So the first one was what allowable devices changed. So the technology platforms, that was one big change. Smartphones were allowed. And the platforms were broadened, okay? Not hospital, trails of connectivity like I have to do through high-risk situations, but just massive, whatever you got to connect is good. Second thing is payment. I've worked with doctors my entire career. Mostly, if it doesn't involve time or money, you're not going to change a behavior, in my experience. But we were not being paid for telehealth. At the time prior to COVID, we had probably only 50% of our states even had parity law that would allow providers to be paid for any kind of telehealth. And if there was some kind of payment guarantee for telehealth, it was limited by the number of services. Now we can have audiology, pediatrics, neurosurgery, women's health, almost anything you can think of, we're now in the process of adapting for telehealth. It's not appropriate for hands-on procedures. So I can't reach through the camera and do anything, although with neurosurgery and robotics, you actually can. So we're actually extending that. So there were a lot of limitations around that, but certainly the services were broadened. My next contiguous state, when we got that call from Montgomery, Alabama, I said, love to come. Your state doesn't pay for telehealth for me. They pay only for 4 specialists. Behavioral health is the most common use of telehealth in the United States today and still is pre and post COVID. They paid for strokes, which we've had in the ER for clot busters in rural areas for 30 years. They paid for pediatrics, they paid for ICU. So my specialty wasn't even allowable. And so the services were the second thing that expanded with COVID. Pretty much now you can get many, many, many services and get access to them. So access to the services that you need was expanded in 1 week. Today I opened my email and I just saw a rundown of all the legislative efforts in the United States going on to expand the service line and make it more permanent. Not passed yet, but in the right direction. The third one was payment. So you heard me reference payment. Some Medicaid's paid, some don't. Private carriers parity law says in a state, if I'm coming to you through AV, I can look at your EMR, I'm going to make the same clinical decisions, you can sue me for what advice I give you, then I have the same liability and the same quality of care and the same responsibility. So you should pay me for telehealth delivered this way, and it should be the same as in person if I can meet the same clinical quality standards, which many times we can. Not often. That is going to be one of the continuing threads we are all looking at post-COVID. What are appropriate clinical decisions by phone, where you don't have reliable, hands-on data, it's just self-reporting. But certainly the service line, the payment, the devices, the last big section to change was licensure. So in telehealth, you have to be licensed as a provider where the patient sits, not you. And so these doctors, pre-COVID, had to have licenses in multiple states to cross state lines. Invariably, the states that had the need for specialists or access to care often had the most strict licensure guidelines. So the fastest we've ever gotten a doctor licensed in these past 11 years has been 90 days. And the longest it has taken has been 3 years to get a license. So that is a big barrier to doctors crossing state lines. Even if you're physically close to me, even if I can pipe it in, I may not be worth me getting a license there if it's too hard to do business. I think that's another customer lesson that we're learning in COVID is you have to be easy to do business with. When you get complicated, I'm going to it's just too much. We all talk about the 80-20 rule where we have those 20% of the customers that take up 80% of our time. You have to make it easy to do business. So those are the 4 big areas that COVID changed services. Now, if I have a state license at all as a medical provider, not me, but the doctors that I employ, pretty much if I call their board, if I give them copies of my license, we can see in this COVID environment in almost any state. And so it's all been thrown out the window. 2 weeks ago, we had our first permanent change from Medicare that will continue past COVID. And it had to do with the home is now where telehealth is happening the most. And it had to do with home payment and home services continuing past COVID, and Medicare is leading the way. So Medicare has been around telehealth for over 35 years. They have also been the most restrictive. So for Medicare to come in and change all the rules in a week and just see the patients, it's been so dramatic, so dramatic.
I can't imagine an industry that has had such a seismic shift and just the complexity of it. All of those 4 points you just went through, I never thought about. I don't think the average citizen would think about, oh yeah, that impacts licensure and payment and all of those things. Talk to us a little bit about the education that like the normal people like us that are just new to telehealth. Last night, my husband and I were watching TV, and every single break, there was a commercial from one of our local hospitals about telehealth. And so I know there's a lot of ad campaigns that hospitals are doing, but what are some of the other ways that the industry is trying to educate us as potential and future customers?
Right, so it's not just us, it's the providers as well. And so one of the things that you don't realize is perhaps you're half of the equation of the connectivity point as the customer, but what if you had the provider doesn't know how to use it either? And so we have now simultaneous education. Our medical schools, our nursing schools, our therapy schools in general do not teach in their curriculum telehealth. They have not. They are now putting together short-term classes like, hey, doctor, learn how to use Teams, like the big Microsoft Teams commercial on TV. And there's still a lot that we can do. So like sharing a screen, if I want you to see your ultrasound report for me, I can put that up and show the patient where the baby's problem is or whatever, but it doesn't connect to anything. right? So it doesn't connect to my billing. It doesn't connect to my electronic medical record. I got to open another app, right in another place. It doesn't give me direct clinical information in a Bluetooth way. It's all how the patient's self-reported. So I would say what you're feeling, Betsy, as a consumer is the same as most doctors in America feel right now. Where do I go to learn? How do I get involved? How can I maximize my time with my doctor? What if things don't go well? I've had one telehealth visit myself to my primary care doctor for a medication refill. To make a long story short, it was on one platform. It took 9 phone calls in addition to the platform, and they still could never connect. We just ended up calling on each other's cell phone. And so it is very much learning on a simultaneous track. So some things, like learning with all of us, it's get educated yourself. For doctors now, the American Medical Association has some modules where they can go and learn the basics of telehealth. Their employers are teaching them whatever platform that they've engaged during this COVID time period, how to use them, but it is still very evolutionary. For patients, we have people that can't see the screen, can't hear. We had one lady that we connected to and she kept doing this. And we're like, what's happening? And she's like, I can't hear. I'm leaning closer because I can't hear. So now we always know that when we're deploying something, we ask people like you to use an external microphone or amplify, or we educate them on how to get their best experience. We were talking right before we came on about the timeliness. So in America, if you're going to a brick and mortar, pretty much wherever we go, whatever specialty, we're in our mind thinking, this is going to be a while, right? Like I'm going to show up, I'm going to have to wait 15 minutes, then I got to go in the back, then I got to go in the exam room, then I got to wait. And what probably is a 5 or 10 minute visit ends up taking 2 to 4 hours of our day. Interestingly enough, in this COVID, for whatever the reason, scheduling or points of connectivity and awareness, we are being much more on time with Zoom calls. And so I think one positive thing has been when they do get it and when the patient has learned how to connect or how to use their device or whatever, and the doctor does the same, when it is going well, it's going very well. And so I think that's very encouraging. Steps to learning are the same steps as we learn anything. Get educated, do your homework. Ahead of your Zoom call, ahead of your remote visit, make sure that you know how to hear, make sure that you have camera, make sure that you're lit, your face is lit. Very simple steps to make sure you write down your questions so you don't forget once you disconnect. They're still not in the room walking out, right? So same thing with doctors, be patient, take your time, do a few free videos, learn, schedule a little bit longer appointment time in case there is a technical problem. Those are things that I think to learn, but we are all learning remotely in America right now. So there are apps that you can use to learn about a telehealth visit, whether you're a patient or whether you're a doctor. I would encourage patients before their visit, try those.
It's fascinating to hear how much has shifted. I mean, Betsy and I have talked about the transformation economy and how people have to learn and have to transform and take on new identities like, well, I'm a doctor and I work in this office, or I'm a patient and I go here. That's all been thrown out the window, if you will, for the moment. Talk us a little bit through the idea of customer centricity, because healthcare traditionally has not been very customer centric. And I think there's probably 2 elements of this from your perspective. So I'll let you take it however you want, but there's the customer centricity, if you will, for the doctors being the customer. So you've got the payment systems, insurance, you've got the technology, all of that. And then you've got the consumer, the actual patient themselves, and the customer centricity that is or is not present there. So kind of give us your perspective on where that's heading and what's happened there.
Yeah, so I definitely agree with you, Tony, in that I believe any business owner, any business organization really needs to think very broadly about their customers. So typically, when you think of just a P&L sheet or a balance sheet, we think of the customer as who's writing me the check. The customer is who's paying the bill. That's who the customer is in my mind. When I think of revenue generation, that's who comes to mind first. But like in my business, I have an unborn baby customer, I have a patient customer, I have a payer, as you mentioned, that really the payer is paying the bill. The patient may not be paying the bill, so they're involved in the mix. And then now, interestingly enough, in this COVID, even though they're not paying my revenue, I'm dependent on the technology piece to deliver what it is I deliver. So now I think of, well, my partners, my strategic partners, my vendor chain, my global supply chain, what have we all learned from the China lesson? When we're having a Cold War with China, when things get shut down, even if you're not sourcing from China, that part that you wanted is from China. And so there is all this disruption. And so I think we need to think of our customer-centric is not just revenue-based. It's who is my revenue dependent on? Where along the supply chain do we have these relationships that all need to come together to actually make the delivery? So I think we're smart to look along the way. Who are our strategic partners that make introductions? What are my vendor relationships like? And do I have one, not my regular chain for a backup? I think that's an important piece of it. With payers, for me, I have a contract with the payers, but we all know, okay, you get your explanation of benefits if you're a patient, and they deny as step one. So now there's all this fighting. I don't want to fight them too much because they could boot me out of their panel. So what is the middle ground that I can both get paid and keep my relationship with that payer going? It's very interesting. So I guess my lesson with the customer-centric circle is really to think not just about revenue producers for you, but who affects that chain and what are the relationships that you need to maintain in that chain. And we try to do that too. A good example with telehealth has been our patient satisfaction. So we do patient satisfaction surveys. Telehealth is a little different. We're all sensitive because pre-COVID, people have told us it's not the same relationship between the doctor and the patient. It's a step removed. It's very impersonal. I can tell you story after story to argue that, but that was the perception. So perception's reality, right? It's impersonal. But now we're thinking, okay, well, we got to connect all the dots here. So how can I make it more personal? How can I make it better? We send out a survey after the first telehealth visit and have for 10 years, just because we've been sensitive to how was your telehealth experience since it was probably the first time you ever had one. And you don't think you'll have one when you're pregnant, right? You don't. And so it was always unusual. Our first patient visits, we would want to say, what was your experience like? Did you get along with a doctor? Do you know what you're supposed to do? How was your audio visual? We're asking questions that won't be asked in a brick and mortar store. And then if we have a frequent flyer or a repeat customer, which is about a third of our patients, we're going to do it after the second encounter also to make sure we start to develop some consistency. And then we're expanding it to, okay, well, the doctors are also in my supply chain because if they don't refer a high-risk patient to me, I will never see the patient. So my customers are also the obstetric doctors that refer, so let's see how happy they are. So, we talked earlier in the broadcast about validating, listening, don't assuming. I think, Tony, that bigger circle and keeping that loop of you better listen, you better ask, you better prioritize, don't assume. That's always the customer lesson for us, right? We think we're doing good until you hear that one thing and it's like, oh my God, I never thought of that.
Tanya, you make such a great point about all of the points in the supply chain, and you don't really think about healthcare in terms of supply chain necessarily, but it's such a good point. And I would add too, the employees that touch the customers on some level. We have a company that's really looking into in their customer-centric vision, including the employees, because they also have to be, line. And they have to be well treated, and they have to have good experiences, and all of the same things.
Even the voice. I mean, how many of us have been? Here's another big shift. If we just say 6 months ago, if we polled all Americans and say, would you source your healthcare online? The overwhelming majority would say no. I'm going to call a friend. I'm going to get a referral. I'm going to ask my current provider. I'm going to get a referral. If someone we know was the main reason how we source things. But now it's all different. We're doing our own resources. And now a lot of it is my experience. If my experience is 6 times I try to get on your platform, I wait in your Zoom call or whatever, I'm direct B2C or whatever, and now you can't even connect on the other end, done, boom. You know, our tolerance online is like 10 to 30 seconds. It's so very short. And we're all used to surfing on the web, fiber speeds, instant. We haven't had instant healthcare. We've had wait for it healthcare. And now, like the point you bring up, Betsy, you make one phone call to a doctor's office. Do you have telehealth? No, done. And so we're sourcing differently. So absolutely, I agree with you that the employees and how they handle and how we train them to look for opportunities, resolve problems on their own, speak to people, to engage and enroll them, and kind of in a way help lead and train them as to what their experience will be if they do choose us is really, really critical. It's a great point.
I think it's such an interesting time for all of this that's happening because, as you mentioned early on, historically healthcare was just something we accepted, these long wait times. And I think that's going to be an opportunity for some in the medical profession, and it's going to be just the worst thing ever for others if they don't learn to shift and be more customer centric. Well, and I find this very exciting for this industry because if anything needs to be customer specific or centric, it's healthcare. What's more personal than your healthcare?
Yeah, we were talking about this when we were doing the prep for the show about the idea of major healthcare systems in the United States were caught with their digital pants down. We even at one point said, maybe that's what we should call the show. Well, when a hospital or healthcare organization loses 40 to 50% of their revenue in less than 5 working business days, because nobody's coming, elective surgeries are out, the government shut you down. No, you know, your margin isn't that probably. And so you're out of business in a week. How do we adapt? As patients, we're going to benefit from a lot of that. And now we just have so many more tools. Nothing is going to replace hands-on procedures. Nothing is going to replace if you're sick, you need to go to the hospital. You have to be sicker and sicker, right? Because now we have home monitoring in telehealth, and we have visiting nurses and micro hospitals and all these other things changing. But you're right, in terms of shifting expectations, shifting deliverables, what motivates a healthcare system to change their conservative ways? Wow, what a lesson we have seen in the past 90 days.
It's really fascinating to me because now, you know, we've got these systems, as you said, that are built around physical facilities. And the meetings industry, which is, you know, a place that I spent a lot of my career, is the same way. Large hotels, large convention centers, there's still a need for them. There's still a need for hospitals. But essentially now, anywhere I am with the right device is a place where a doctor or a nurse practitioner, exactly, my phone, that they can meet me there. So it's like the cost associated potentially with healthcare can actually come down. It won't happen immediately because we still have these facilities out there that we've spent a lot of money on, but eventually the cost can come down because now I don't need to have a brick and mortar location to do a lot of the things, a lot of the basic things that need to be done in healthcare. And probably some of the more advanced things too, we can have a different approach to this, which is exciting, I think, because of what's going to evolve out of this. But you did talk with us during the prep session about something that I think is a concern. And that is, we alluded to a little bit earlier about the education, but you talk about how there's just not enough people in that telehealth space yet. So give us a little bit of maybe what keeps you up at night right now because of this change, maybe not specifically for your company, but maybe broader for telehealth as a whole.
Well, I think a couple of things. One is we're going to have to train the workforce. We're going to have to train the workforce to catch up with this gap. Because right now, I think in the past 90 days, people have learned to do a Zoom healthcare call, but not much beyond that. And we are going to have hospitals making it after they catch their breath from this loss that they've had. We still have major organizations that have furloughed hundreds and hundreds of healthcare workers, and hospitals still not up to where they were before because of COVID and people not coming in. we have this kind of gap between the need and the ability and the competency level for what all will be required, not what's the easiest low-hanging fruit to be required. Just so you know, the federal government has a National School of Applied Telehealth. It is very basic. It hasn't been updated in probably 10 years, but it does offer basic level training for the telehealth presenters. People are kind of responding in a very scratch the surface way, but we'll go deeper and deeper and deeper the more that we get connected. So addressing through formal education programs in our medical schools, in our nursing schools, they're going to have to add curriculum now. They're going to have to do online training. Patients are. So there's a lot going to be changing. If you just Google telehealth training, I'm a trainer, where do I go to get telehealth training? You're not going to find very much right now. So people will be filling that gap, and I know people are doing that. So I think that's one thing, is that a worry I have is that we're going to have some things we can do by telehealth. We can do a lot more, but there's not people that know how to do it. Like, who knows how to connect all the dots to get an ICU feed to a doctor? A lot of hospitals aren't set up that way. So we have to address the education gap. The other thing that I'm watching with bated breath, and just as somebody who pays a lot in malpractice insurance for the doctors that we have, we're looking at reliability of data. And so, data has been coming around. If you think of a Zoom call, if I say, I have an ear infection, I've had a fever, my ear hurts, it's this ear, it's red, it's inflamed, look at it, whatever. There's no reliability there. I mean, for all you know, I stuck a toy in there. You can't see anything. There's not an otoscope in my home. You don't really know if I have a fever. No vital signs from a thermometer have come into your data bank. And there is self-reporting, and then there is real-time true data. And this is one of the biggest discussions going on in telehealth, is what is the line in the sand of appropriateness and adherence to a clinical standard, so that for the information that's given, it's reliable enough for the provider on the other end to actually make the same quality, same standard of care clinical decision. So a good example in my business is we have about 40% of our pregnant women in my practices are diabetics, or gestational diabetics, or insulin, or type 2 diabetes. Very high percentage. We will tell them all the time, tell me what your diet log says. Tell me what you've been doing. Oh, I've been adhering to my diet. I'm doing great. My blood sugar's this, it's that. But I don't have the glucometer coming straight from your blood test to me as a doctor. So it's just what you report. Then I say, well, I'm going to have your OB draw your A1C level, and we'll see how compliant you've been. Then we get the real number. Nothing like I've been compliant every day. Totally mismatched. And so we are going to come into having to connect the data to the self-reporting and matching it up and paying appropriately for appropriate levels of care. And so this is where one fabulous thing in telehealth that was happening pre-COVID and will continue is telehealth technology itself changes. Used to be that we had these big bulky carts. They had to go through a codec to get the real, to get your EKG from your chest pads to my screen. Used to be a lot of wires and connectivity and open portals and going through firewalls at hospitals and that kind of thing. Now it's like pairing apps. It's like pairing up your iPhone to your car stereo. It's like apps and a laptop. And so where we used to have big bulky equipment, my first bit of equipment investment was about $35,000 per unit. Now the system, I can do the same thing with a laptop and with apps and with Bluetooth technology for about $5,000 to $6,000. And so we're going to be able to spread that out and do a lot more. But again, one of the things that keeps me up is self-reporting as the only input I have as a provider, my malpractice, my payment, and everything being, dependent on that. But it's not true clinical data. We're going to have to connect the dots so that doctors can see EMRs easily. They can move images and pictures around easily. And there's Bluetooth technology in the home that's real and not self-reported. The third thing I'd say that keeps me up at night in telehealth is it's been fabulous to have jet fuel to your adoption in your business. But what is staying and what is going back to the way that it was? So a good example of this is Hipaa Compliance. So protected health information has been a theme for American healthcare for years and years, decades. I don't want everybody to know my business. I decide who gets access to my healthcare, and I own my own healthcare data. Okay, well, when we threw all that out the window, I could be sitting in your driveway just parking in on your Zoom call, right, if you didn't set it up right. And so I think this whole issue of security, coming back around to security and protected health information, is one of those things that will be repealed. It will be, you have to be on a HIPAA compliant platform. FaceTime isn't going to cut it for now and forever. So that's an example of going back. Going forward, we expect payment, so like Tony, you mentioned, okay, well, if I don't need all this brick and mortar, why am I paying $100 a visit for 2 minutes of your time for a medication refill? It should be like $10, right? So I think this reform of what will go and what will stay from the lessons that we learned, for me, every day in the news, it's like drinking from a fire hose. Like I said, this email this morning, I looked at probably 20 or 30 bills that are pending in states right now about changes that may be coming. And so we are all in telehealth waiting to see what's going back and what's going forward. And it will be expanded for sure from where we were. We will never go back to the way that it was and the requirements ever. We will never do that. But how far will we go? What will be paid? What will be allowed? What will be the new rules? That is all to be determined. So again, talking to customers, when your business is evolutionary like mine is at this very moment, how do we truly keep our pulse on? Where is our network of, where we get information, what's the correct information, how does it apply? And it's now regionalized too, because states control a lot of the telehealth money, not the feds. And so you have to keep up in multiple places. But a good lesson for keeping up with customers and listening is you have to stay current. You have to stay relevant. You have to know what's happening. To me, it's like the hyperspace, right? So in Star Wars, it's like we're cruising along, then we hit the hyperspace button. It's like, boom, we're out of there. That's kind of how it feels to me now.
Tanya, as much as you in your role in your industry have to stay on top of it, I think it's incumbent upon us as potential telehealth patients to do the same. I mean, I want to know, where is this going? What does the future of healthcare look for me as a non-healthcare person? This is just phenomenal to me. I can't imagine a bigger shift for an industry. I know a lot of industries are going through shifts. A lot of companies are having to think differently, but healthcare touches every single person. And this has just been a fascinating conversation, Tanya. One of the things that we enjoy doing on the show is giving our guests an opportunity to give a shout out to a nonprofit, a community service, give back, some type of organization. Is there one or two organizations that you really would like to put a spotlight on that are doing good things out in the world?
Well, I think there are many, wherever you sit and wherever you're listening from. Rather than name one, a couple of things that I'm worried about that I think are more localized than anyone could find is we have a lot of homeless pregnant women right now in America. And so we don't think of them. They're not coming in for health care. They're appearing for delivery, may have gotten antenatal care, maybe not. One of the things that we do is we help support a homeless pregnancy shelter here in our hometown that we know, and we talk to them and we know those kind of things. But I think that just the whole COVID industry, I was reading an article this morning, something about, a very high percentage of Americans are having to move. They don't have income, they're having to move, their support system is disrupted. I would just say, we think traditionally in America as pregnancy is a time where it's happy news, it's happy times, it's happy babies, it's chubby little cheeks, and, a lot of good. But there's people really, really struggling. So whether it's the homeless shelter or the women's shelter or something like that, I would just say, look around your community, support how you can, whether that's through dollars, time, awareness, or reaching out, or donations, or whatever. there's a lot of women that do not have resources in our country, and they're kind of invisible, I think. So that would be my big plug, and I sure appreciate the opportunity to pass that along.
Thank you, Tanya. That's so important that you brought a spotlight to that. So thank you for sharing that. Tony, any other questions for Tanya?
No, I think we covered a lot of ground. I really appreciate this, Tanya. It's opened my eyes, and I think there's a comment you made that I just wanted to reflect on for a moment, and that is, you said we're never going back. It's like the rubber band has been expanded. It's the human mind being that rubber band. It's never going to go back to the way it was. I also think that while it will contract to some extent back toward where we were, we've also given technologists and physicians and others this ability to foresee what could be. And so they will find a way to now push that envelope even further over the next 5 to 10 years. So whatever does contract back, we will push it out again because we've had this vision and this reality for a few months at least.
I agree with you, Tony. I think the other interesting thing right now is because of COVID, we have more cooperation on the planet in healthcare than we ever have before. There have been a number of proprietary lines. And so we are learning from each other, and not just in the US, but even with telehealth globally, we're supplying other countries right now. We actually are working in Kenya right now with high-risk pregnant women. So I think not only the rubber band, but the space in which the rubber band is working will be bigger and bigger and bigger too.
Yep, the world's getting smaller all the time. Tanya, thank you so much for your insights. This is just fascinating work you're doing, and I'm definitely going to be following along and want to stay in touch. Thank you so much for taking the time to talk with us today, and I'm sure that our listeners are getting great value from your perspective on the customer experience in such a dynamic, changing industry.
Well, Betsy and Tony, I'm sure you can tell I'm passionate about telehealth, and I'm happy to be in it and happy to continue to be in it. Thank you for giving us a voice today. Absolutely.
Betsy, I'm almost speechless here, but I'm going to talk anyway. I'm going to come. This interview has me just reeling a bit because I don't know where to start. We've never experienced in my lifetime that I can recall anything close to the type of disruption that we're seeing in healthcare right now, and disruption from an oh my God, what are we going to do situation. I mean, hospitals losing 40 to 50% of their revenue in 5 days, but also disruption, which I would call more transformation, the positive side of it. Like, we're having the laws rewritten in 7 days. And we're having the regulations rewritten in 7 days. It's like, we have never, as far as I can point to in my life, seen something like this happen. And I mean, I've been through some telehealth myself, and with my family and that over the last few months, but not realizing all that had to happen. It's not as simple as just popping open a Zoom call and having a little chat with a doctor. I had no idea all of the work that had to be done on the back end and why it took them time to be able to respond this way. But, even as Tanya kind of talked about a little bit off air, is that the CEOs of these hospitals are still reeling. They don't have an answer. It's not like it's going to be something that's resolved immediately, but it is definitely something that is going to affect us long term.
Yeah, and as you said about the CEOs, they're fighting for survival versus, hey, how can we adjust our business for the future? They're trying to get through today, which I thought is just, so daunting in light of all of this disruption. The other thing that strikes me about it, Tony, is, when we talk about disruption, there's been disruption in the music industry and disruption in the automobile industry and all these different disruptions that are big and affect a lot of people. But in healthcare, it's bigger than anything, and it affects everybody. And so I think what Tanya was talking about on so many things, payments and training and data and compliance, all of these things that have to be addressed, it's going to be years, if not decades, for this to shake out. And I think, as I said in the interview, it's incumbent upon all of us to stay on top of this and understand how it affects us personally and our family and our loved ones when it comes to telehealth and where it's going.
Absolutely. I think another element to this that holds much promise, and I think it gives us good direction for the future, not just in healthcare, but I think Tanya did a great job of talking about all of the cooperation, the payers, the vendors, the technology devices, all of this cooperation that has had to happen in a very short period of time. And you mentioned the automobile industry. We've seen how automobile manufacturers, because they don't need to make cars when people aren't buying cars, they switched over and start making medical devices. That's just one example. I really do believe that as we move forward past COVID, past the quarantine and the lockdown and those situations, that business's path forward is really one of cooperation as opposed to the competition that we've seen before. We're going to find better ways to strategically work together. It's like bringing a specialist into a hospital. They could have been seen as competition in the past, but because there's limited specialists, they're actually cooperating. And she's been doing this for, 10 or 11 years, as she said. But that's something I think as we start to look at our businesses and if we get to know our customers, really know our customers better, right? That will allow us to say, here's who we can serve the best. Here's who, one of our past shows, I think it was Ross maybe, he said, my ideal customer is the one who I can help succeed. And that to me stands out. I could keep going back to that because in this case, how can I help the patient? Who can I help be successful? And narrowing the customers I serve by who I can serve the best, and then finding strategic ways to partner with other people to make that happen better.
Yeah, I think that's a perfect way to conclude this, because that is absolutely what we all need to be asking ourselves. Who can I serve the best? And how can I bring in others to help make that happen? So with that, Tony, I think that's a good place to wrap. Thank you again, everyone, for being here. We're so appreciative of the comments that we've gotten on the podcast. We'd greatly appreciate it if you enjoy our show. Drop us a quick review on whatever platform you're listening to this show on. And we want to keep doing this. Tony and I love bringing this content to you and these amazing guests that we've had. So with that, thank you. And we'll see you next time on the Really Know Your Customer podcast.
Thanks for joining us for this episode of Really Know Your Customer. We hope you gained a lot of value from being here today. If you want to learn more about the work Betsy and Tony do to help their clients thrive, visit Betsy at thecongruitygroup.com and Tony at tonybodoh.com. See you next time on the Really Know Your Customer show.